Afternoon, sir.
Okay, yeah, am I audible?
Yes, sir, audible.
17 लोग हुआ।
Thank you for your patience. Thank you so much. Good afternoon, respected panelists, our dear colleagues, and my juniors, those who have joined, and all the participants in this. Just a second. Sir, actually, उन्हें के join करेंगे. Today we have all gathered here online this afternoon on the occasion of World Sickle Cell Day, and as we all know, that sickle cell disease has been included as a disability in the RPWD Act of 2016. So we have gathered here with the objective of gaining more. We have gathered here with the objective of increasing awareness about this disease, particularly understanding why it has been included as a disability and what is the importance of newborn screening and why knowing your sickle cell status in the community is such an important factor. So we have today amongst us respected and eminent panelists who are specialists in their respective fields. So without further ado, I will begin the program. So first, I would like to invite the director of NILD, Dr. P.P. Mohanty sir, to begin the program with a keynote address. Sir, please.
Thank you. Very good afternoon to all of you. The faculties, head of the department of NILD and various participants, very good afternoon to all of you. On behalf of faculties, staff, students, and the Divyangajan of NILD, I welcome all the participants for this webinar. You know, in the RPWD Act 2016, blood disorder like sickle cell anemia, thalassemia, and hemophilia as bleeding disorder has been included under the disability, and as per the direction of Department of Empowerment of Person with a Disability, we organizing various events on each disability related dates. So today 19th June is the Global Sickle Cell Day. The theme for this year is building and strengthening global sickle cell communities, formalizing newborn screening, and knowing your sickle cell disease status. Sickle cell anemia is a genetic disorder, is an autosomal recessive disorder. So both the parents, they are the carrier or maybe they are the sufferer, and from the parents it transmit to the offspring. Sometime when both the parents are, it's high risk of having the child developing this sickle cell, where we have eminent expert, they will tell in detail. So as I know, the hemoglobin, which is oval or rounded in shape, that become curved, that become sickle in shape. So it obstruct the small vessels, the capillaries. As a result, the circulation to the various part is affected, and one develop various disorder, even stroke. When the circulation is affected, one may develop the stroke even, and various musculoskeletal problem and disability patient develop. So NILD dealing with the locomotor disability, we have to deal with those musculoskeletal problems that arise from the sickle cell anemia, and we have to
Sir,
strengthen our
job के लिए problem आती है काफी. That is a suffering like job, employment. How to get employment?
yes. So as a national institute, we have to strengthen our patholab. We have to strengthen our in diagnosing those conditions. And screening is very important. Of course, develop the infrastructure in our NILD for screening, those genetic study and all, but it should be, expert enough to advise the, people, the appropriate place, hospital where the screening also can be done, so that prevention can be done better, and early diagnosis is also better. In those cases, we have eminent expert like Professor Tufan Kanti Dalai, head professor and head of the department hematology, NRS Medical College. So, on behalf of all the faculty, staff, student, and Divyangajan, I welcome you, sir, for this webinar. We're really privileged to have you, and the participant or postgraduate student and all will be definitely benefited. Then we have Dr. Imran Malik, our one senior residence PMR. He also is one of the speaker. He's going to discuss various complications that arise, musculoskeletal complications that arise in sickle cell anemia. Without wasting much time, I welcome all the participants, and I'm thankful to our coordinator, Dr. Subodip Das, who has arranged this program. Thank you all, and again, welcome. Thank you.
Thank you, sir.
Thank you so much, sir. Now I would like to invite Dr. Tufan Kanti Dolui, who is the professor and head of hematology department of NRS Medical College, to speak about sickle cell disease and its perspectives in India. Sir, please.
Okay. Thank you very much, and good evening to everybody. Am I audible?
Yes, sir, audible.
Okay.
Good morning,
Yes, sir,
sir.
you're audible.
Good evening.
Thanks for giving me the opportunity to speak on this the sickle cell disease in the August audience. So now I'm sharing my slide first. My slide is visible.
Yes, sir. Visible, sir.
Okay. So thank you very much. So I'll be speaking on basically the overview of the sickle cell disease. The before going to the disease proper of the sickle cell disease at the NILD, I'm really thanks to the NILD, the director and the Dr. Subhadeep and the others who have been arranging this program of the sickle cell day. You know, the sickle cell patient has always become a neglected, and the people are not looking properly, and they are not realizing they are the needs, and also they are not realizing they are the disease status and the conditions. And also the recently the government in India have been launched the sickle cell eradication program by the 2047, and also fund have been allocated. So thanks to the government of India also. So things that the sickle cell community is becomes the important community, particularly the tribal population. They have been involving and they have been affecting the different kind of the disease called the sickle cell disease. So, on behalf of the World Sickle Cell Day, 19th June 2023, as the director said, is rightly pointed out, the theme of this year is the building and strengthening the global sickle cell community, formalizing the newborn screening, and knowing the sickle cell disease status. So, knowing the sickle cell status is becomes very very important, and that is becomes very pertinent in this part of the country. You know, the India there is no disease database is there. There is a few scattered database across the country in the different tertiary care center. So overall in India, there is no epidemiological study on the sickle cell disease per se. You know, the sickle cell disease is basically a monogenic disorder. In the beta chain of the sixth position, the glutamic acid is replaced by the valine, and these the replacements of this the beta chain that lead to the main pathogenesis of the disease. The RBC become deformed, and that leading to the stickiness, obstruction, and the hemolysis. But there is a lot of the heterogeneity of the disease of the sickle cell disease.
Sickle cell disease সঙ্গে পড়ছি
Hello. So in terms of the sickle cell disease, you know the normal RBC shape, and then in the sickle cell disease, the RBC becomes sickling in the shape, and this sickling of
জল
the
দিতে
cells
হবে
that lead to the lot of the problem in the patient per se.
হ্যাঁ
And not only the patient per se, the more important thing is that in the terms of the sickle cell, that not only to the sickle cell population, but also
Yes,
there
sir.
the parents and the family becomes involved into this group of this disease. So this sickle RBC is becomes main pathogenesis of the sickle cell disease. If we go to the prevalence of the sickle cell disease across the India, that in India the majority of the cases the disease is more common in the Madhya Pradesh, the Chhattisgarh, Uttar Pradesh, Bihar, Jharkhand, and also the Assam. But in the other part also the Rajasthan and the Odisha and subsequently the Arunachal Pradesh and the Meghalaya, they have a increasing prevalence of the sickle cell disease, and also the part of the West Bengal and the other part of this country there is a scatter case of the sickle cell disease is there. And in terms of the sickle cell disease management, the program, there is a four states. They have a specially designed program for the sickle cell disease. Is starting from the Gujarat, from the Odisha, the Maharashtra, and the Chhattisgarh, and they have been initiated this sickle cell program in their state level. What about our the West Bengal? We are much ahead about the other state of this the India, because the government of the West Bengal we started the initiating the thalassemia control program in 2009. From that 2009, we are doing the activity in terms of the all hemoglobinopathies, that including the sickle cell disease also. In now, we have been screened more than 19 lakhs of the people. In this 19 lakhs of the people, the sickle cell anemia is 531, and the sickle beta is 954, and hemoglobin S carrier is 8605, and the carrier rate is less than 1%. If we consider the disease status, is 1458 people they have been suffering from the sickle cell disease. The
Sir,
beauty of the sickle cell into the part of the West Bengal is that the double heterozygous, that is the sickle beta thalassemia, this communities becomes more comparing to the sickle cell anemia due to
ex-
the
excuse me, sir. Excuse me, sir.
yes,
Sir,
yes.
sir, your slide is not moving. Please speak
My
better.
slide is not moving now.
Yes, sir. Yes, sir.
So this is the problem of Google.
Sir.
So now it is moving.
Yes, sir. Yes, sir. Yes, sir.
Now it is moving.
Yes, sir. Yes, sir.
Please, please say slowly,
Okay,
slowly.
okay, thank you. So I have been
Too
covering
fast, please, sir.
I have been covering this what is the sickle cell, then come to the talk about the sickle cell update, then this is the single chain monogenic disorder, where the chronic acid becomes like honey, and the RBC becomes suspected that lead to the problem of
सोम्या सर माइक बंद कर दीजिए अपना सोम्या सर
sickle cell disease. And then you know the prevalence of the sickle cell is more common in this part of the country. I tell you. And in terms of the program, the Gujarat, Odisha, Maharashtra, and the Chhattisgarh, they have a program. In terms of the West Bengal, we have been go ahead. We have around 1,558 patients is there into the West Bengal, and we did this program since 2009. So the carrier rate and the sickle beta and the sickle cell anemia is quite high in this part of the country. And so sickle cell patient, this is the distribution according to the district of the different West Bengal. That in the majority of the cases, the disease is more common in certain part of the district, particularly the Paschim Mendipur, the Purva Mendipur, the Purulia, the Jhargram, Bankura, and also a little bit of the Alipurduar and Jalpaiguri. These areas, the sickle cell is more common. In terms of the sickle cell disease, the main problem of the sickle cell disease is the painful crisis. Why the painful crisis? I may come in subsequent slide, but the main problem of the sickle cell is the crisis. That crisis lead to the acute chest syndrome, there is a vaso-occlusive episode, the infection, splenic sequestration, and there is a plastic crisis in the stroke. And also in the long run, there have a lot of the problem in terms of pulmonary hypertension and the hemorrhagic stroke and so on. So pain is the hallmark of the sickle cell disease. That the pain is the very very important thing that need to be known by the patient and the patient relative. Depending upon the visual analog score, we have been identified the severity of this the vaso-occlusive painful crisis, because sometimes the mild pain the patient may not notice, they may not notice to the healthcare facility, the healthcare fraternity for the treatment of the disease. But the vaso-occlusive crisis is the very very important and is the hallmark of the sickle cell anemia. That is, each pain is usually lasted for the 10 to 11 days. They have a prodromal phase of the pain, they have an initiation phase, then come to the established phase, subsequently the resolving phase of the vaso-occlusive crisis. This is the recurrent vaso-occlusive crisis that lead to the deformity of the joint, that lead to the damage of the joints, and also the joints and organs, and ultimately lead to the chronic pain, particularly if the patient has avascular necrosis is there, there the recurrent pain is there. In the vaso-occlusive crisis, sometimes is not be detectable by the patient and the patient relative. If they come to the medical fraternity due to the severe pain, then only we document that the vaso-occlusive crisis. But mild moderate pain is a part of the vaso-occlusive crisis, so we should be trained adequately trained to the people, because this vaso-occlusion is the hallmark of the disease, and that have to be identified, and that has to be treated very early. Because in terms of the recurrent vaso-occlusive crisis, there is multiple joint have been involved. It's starting from the brain, patient presented with the stroke, patient presented with the sometimes there is a kidney failure, and there is a problem of the lung, acute lung syndrome, or chest syndrome, and also the pulmonary hypertension. And in terms of the liver, that lead to the vaso-occlusive crisis, recurrently leading to the chronic liver disease, and ultimately it affect the multi-system organ in terms of the liver. Why this happen? It is due to the vascular occlusion by the sickle cell. This vascular occlusion of the sickle cell that lead to this sickling of the RBC, and this sickling of the RBC that lead to the occlusion of the particular type of the capillaries, and these capillaries leading to the blockage, and the supply to the blood to the distal organ has been totally abolish. But the more recently, they have a four important pathogenesis of the vaso-occlusive crisis. First is endothelial activation by the nitrogen oxygen species become very very important. Then come to the endothelial adhesion by the E-selectin, P-selectin, and L-selectin, and there is an involvement of the neutrophil, the platelet, and the other inflammatory markers, and ultimately lead to the polymorphism of the particular genes that involving into the pathogenesis of the sickle cell crisis, and ultimately there is a chronic hemolysis, and that lead to the low hemoglobin. So this is the main pathogenesis, how the painful crisis is there, how the RBC, how the sickle RBC that blocks the capillary, that lead to the several complications of acute complication come to the chronic complication. In terms of the acute complication, patient may present it with acute chest syndrome and the acute pain events. There is septicemia is there is splenic infarct and the splenic sequestration is there, and also there is some painful crisis here and there also, and sometimes there is a retinal infarction is there, sometimes the stroke, gallstone, papillary necrosis, the priapism, and the bone infarction, osteomyelitis. In terms of the chronic problem, there is a lot of the chronic problem. It's right from the head to toe. There is a neurocognitive dysfunction is there. There is a liver involvement. Sometimes there is a chronic liver disease is there. There is a vascular necrosis, the retinopathy, pulmonary hypertension, the heart failure, and there is a functional asplenia. There is a persistent and the chronic leg ulcer and the chronic pain. These are the common clinical symptoms that the majority of the patient with sickle cell disease. If we consider the disease in the sickle cell in the children and the adult, that's little bit the different. And also the more important thing is that in terms of the India, the haplotype of the sickle cell disease is slightly different from the haplotype of the America and the Africa, because our patient has a Indian African haplotype, and in that group of the patient, usually the symptomatic after the age of the 2 years. So before the 2 years, usually there is no symptom in majority of our Indian patients. After the 2 years, they have a majority of the symptoms that started from the recurrent infection, the dactylitis, recurrent painful crisis, and all these things is there. And into the adulthood, there is a lot of the problem with the lung disease, the heart disease, the brain disease, and also there is a problem of the kidney failure also. So to confirm the diagnosis of the sickle cell disease, we have a gadgets called the high performance liquid chromatography, or we have the capillary electrophoresis. By these two technique, we have to identify whether the patient has a sickle cell disease or not. Because this sickle cell disease is a disease had to be identified by the electrophoresis, and this electrophoresis becomes routinely available in the majority of the state. Next come in terms of the treatment of the sickle cell disease, there are a lot of advances in the treatment of the sickle cell disease. From the first case reported from the 1910, then in 2019 and 2023, there is a lot of advances is there for the treatment of the sickle cell disease. If you consider the nutshell of the treatment of the sickle cell disease, there is a chronic transfusion, there is a treatment of the complications, there is a prophylaxis of the antibiotic and the vaccines to prevent the infections, and also the different drugs to treat the patient with the sickle cell disease. But the more important in terms of that, the supportive therapy in terms of the folic acid that has to be given each and the every patient. In terms of the other current therapy, that the treatment is basically the two types. One is that is the curative treatment by doing the allogeneic stem cell transplant and also the gene therapy, and the other portion is the prevention of the crisis. These are the drugs that can prevent the crisis. This is the four drugs, particularly the hydroxyurea, more recently the crizanlizumab, the voxelotor, and the L-glutamine. These are the four drugs. They will prevent the recurrent vaso-occlusive crisis, and ultimately the chronic problem of the sickle cell disease becomes completely abolished. So these drugs has become very, very important to prevent the disease. More recently, the crizanlizumab has been approved monoclonal antibody to prevent the vaso-occlusive crisis. Sometime in the sickle cell disease, we require the transfusion during the pregnancy, during the surgery, during the severe chronic anemia, and during the clinical stroke. So in that group of the patient, we have to give simple transfusion. But in sickle cell disease, that the transfusion should be used judiciously because the hemoglobin level will be maintained around the point of not more than that. If you give more transfusion, there is a chance of more vaso-occlusive crisis will be there. So sometimes we have to do the extra
Excuse
transfusion.
me, sir.
Yes.
Sir, the slide is not moving yet again. So could you just check if this is the slide you want to show? Yeah. Yes.
This is moving.
Yeah, yeah, we have moved to the slide. Yeah, it has moved to the transfusion slide now.
Okay, okay.
Transfusion in sickle cell disease.
Yes. So then come to the different drugs therapy and the open for the sickle cell disease. That I already told you that the hydroxyurea and a lot of the other drugs is there for the treatment of the sickle cell disease, and the several drugs has been go forward, crosses the phase 4 trial, and that into the market, and we are doing regularly in routine practice. In terms of the definitive therapy of the stem cell transplant, we call the allogenic stem cell transplant. And allogenic stem cell transplant has to be based on in the age of the 7 and 8 years in the HLA hydroventricle transplant. And if the patient has a recurrent stroke, patient has a lung disease, there is a neuropathy, there is a nephropathy, we have to do the stem cell transplant or allogenic stem cell transplant, and these are the curative of this the sickle cell disease. But the more important thing is that the problem of the sickle cell disease across the age is different. It is from the early age we have to prevent by giving the bone marrow transplant, the gene therapy, to prevent the recurrent problem with patient with sickle cell disease. But when it is not possible, then we have to treat like other treatment, prevent the crisis by doing the hydroxyurea, by giving the crizanlizumab, the voxelotor, and the L-glutamine. We call the palliative therapy. Sometimes we require transfusion also, so we have to give transfusion also. In terms of this treatment of this the recurrent painful episode, we have to treat with analgesic, the opioid, and all these things. The priority recurrent episode, the infection, the acute coronary syndrome, and the several other problem has to be treated very aggressively in people with the sickle cell disease. And if you treat it, then the majority of the sickle cell disease they become landed to the adulthood and they have a the normal life expectancy. But the more important is that the prevention of the vaso-occlusive crisis. We have to prevent the crisis. Means there is a recurrent pain has to be prevented. So in that scenario, the hydroxyurea, crizanlizumab, voxelotor, and the L-glutamine is the drug of choice to prevent the recurrent painful crisis. And if the pain is there, then we have to treat the disease of the sickle cell disease. So vaso-occlusive crisis prevention is become very, very important. There is a lot of challenges and the unmet need in Indian context, particularly the more important is how to define the vaso-occlusive crisis. Sometimes the mild pain or the pain require hospitalization. These are the important things because the vaso-occlusive related pain is vary from patient to patient, and the management from the acute and the preventive setting is different. Another thing is that the majority of the Indian setting, the emergency department is not ideal enough to treat the acute painful crisis. And another thing is that sometimes the healthcare providers are not aware of the disease of the sickle cell and about the painful crisis management. And also we have to establish the VOC care model in a multifaceted way. In terms of the sickle cell disease in India, there is a complex population, complex genetics. There is a high frequency, particularly in the tribes. Some, the incidence is 1 in 44. 1 to 44%. So there is a high, very heterogeneity of the populations of the sickle cell disease, and also the magnitude in India. We don't know what is the exact type of the exact number of the patients with the sickle cell disease, and also the morbidity, mortality, the clinical course, the infection rate. All that data is limited, particularly in terms of the tertiary setting. And in terms of the intervention strategy, we have to aware the patients, the public, and also the physician, the caregiver. And the more important is that we have to prevent the disease by the newborn screening, the training of the healthcare professional, and developing the protocol for the treatment. And the more important thing is that we have to set up an advocacy group for the research, and also we have to convince a brocade that we have to concentrate on the sickle cell disease. If you are able to do that, then only our the rural people becomes get benefited. And if there is any problem is there, they can go to the outpatient department of the health center or the rural hospital, and they becomes tested for the disease of the sickle cell. And in the down the line, if there any pain is there, they can attend to the emergency, they get admitted, and they receive the proper treatment of the patient with sickle cell disease. Prevention is the very, very important. The antenatal and the newborn screening technology, the school screening technology has to be identified, has to be implemented into the primary district and the tertiary care level. Then only we can prevent our sickle cell disease. With this, thank you very much for the patient hearing, giving me the opportunity to speak on the sickle cell disease. And lastly, I say that the sickle cell disease is the complex disease, the heterogeneous kind of the disease. We need involvement to the lot of the stakeholder, is starting from the patient group, and all the people should work together. Then only it will be possible to do this sickle cell disease. With this, thank you very much for the patient hearing, and I'm happy to answer some questions.
Thank you so much, sir, for such a lucid presentation on sickle cell disease and its many aspects and challenges in India. Now, I would like to invite Dr. Ikram Malik, who is the senior resident in
Sir,
physical medicine and rehabilitation.
excuse me, one question is there, sir.
Yeah, yes,
Sir,
Yes.
sir,
yes.
I
Please
would
go
like
ahead.
to know that when these sickle cell anemic patients will come to us due to their disability, and when should they attend our institution for their disability or handicapness, so that we can interfere, we can serve our services to them.
Right, right. So there is a nowadays, as our director said, he pointed out that there is a sickle cell disability is there. So disability grading and all these things is there. So we can send the patient to your center for the management and also the different disability management. We are happy to do that.
Okay, sir. Sir, thank you very much.
Yes, yes.
Thank you very
Thank you.
much for your attendance. Just for one call, sir has agreed. Sir is so busy, but he has listened our request, and then and there only with 1 day preparation, he has shown so nice slides and lectures. Thank you very much, sir.
Okay, thank you, thank you.
Thank you so much, sir. If there are any further questions, we can take them, or else we can go ahead. Okay, so now I would like to invite Dr. Ikram Malik, who is the senior resident in physical medicine and rehabilitation at NILD Kolkata, for his presentation on sickle cell disease as a disability and its prevention and management. Ikram, please.
Thank you so much, Dasar. Thank you, sir, for giving me this opportunity speaking today. So I am able to see the slides, Dr. Das. The slides visible?
No, we cannot yet see your slides.
One second. Uh,
Yeah, we can see it, but
yes. Okay.
yeah, it's nice now. Okay.
Yes. Okay. So I'll start with my topic. I hope I'm audible.
Yes, you're audible. Yes, you're audible. Please go ahead.
Okay. Okay. So my topic is on sickle cell disease, the disability prevention and management. Okay, so before we go on to the disabilities caused by the sickle cell disease, as sir has rightly explained, he has told about all the complications arising from the sickle cell disease. and about how to treat them, and also he has given us a brief outline about the disease. So I'll be speaking more on the disability aspect. Okay, so before that, we need to have a little bit of an idea of the what exactly the disability because of the sickle cell disease is. So if we give a generalized term, so disability refers to restriction, the type of activities and the social participation which the individual can perform, which is result of the physical or mental impairments or conditions which are a long-standing duration within an environment that does not provide a sufficient accommodation to facilitate participation. So this is in relation to the sickle cell disease. So we know there are various disability models, and based on that, we can classify the various type of disabilities and how to prevent them and make certain ideas. So the functional model of disability is operates on the individual level. That is more important for us here, because the individual is of concern rather than the society or the what we say the society or the group, because we need to treat the individual directly here. Okay, here on social model of disability on the social context, which the disability is seen, which can be either the social disadvantage or the exclusion from the society, which may be arising because of our particular disease. Okay, so we have seen about the sickle cell disease. These are the chronic conditions that may lead to disability, or which are the result of the primary impairment, or it can even be because of the secondary conditions or complications which are arising from the particular disease. So we need to know the physician, patient, and family awareness are all important to detect the disease at an early stage, so that now we can not only manage clinically, but we can also lessen the effect it has on the society, and the educational interventions can also be done at the earlier level. Now, in sickle cell disease, the most important thing is the prevention of complications that can prevent or reduce the disability and to promote the goal of full and active life. We need to control and manage the disease symptoms so that we promote the healthy behavior among the patients with the sickle cell disease. So little bit of data. So the people with the hemoglobin, that is the S by or thalassemia, they have the similar severe disease like the HBSS homozygotes, whereas those with the thalassemia, they typically have the mild to moderate symptoms. But in sickle cell disease, it is little bit different. The symptoms are mostly arising because of the clinical complications. So the sickle cell disease, that in the 1980s, the study was done. They projected the median survival rate for the sickle cell disease for the SS type, that is for 48 years for women and 42 years for men. And those with the SC type of the homozygote, that was 68 years for women and 60 years. Okay, so the impact of sickle cell disease on the disability can be mediated by the etiologic mechanisms. So as I said, first thing and most important thing is the vaso-occlusive events, also called the pain crisis. And again, next is the organ dysfunction. And again, other than the physical aspects, we have other aspects also, like the depression, sensory impairments, which can be of vision or hearing. That is due to the end organ failure. That can be due to damage to the end arteries. Then we have anemia, bone disease, and so pulmonary complications. So again, here the moderate to severe anemia is the common feature of sickle cell disease. Okay, so I'll just list out a few medical complications which are arising because of the sickle cell disease. First is the AVN, that is the avascular necrosis of the hip joint. So all these are because of the basic thing, that is because the RBCs are not in the proper shape. There's a sickle cell shaped, and because of that, the blood is not able to flow in its natural reservoir. There's a problem in the supply to the various organs, that is the major organs, and also to the joints also. So again, we have the acute chest syndrome in adults. They can sickle cell pain crisis. Again, stroke, which is very important complication because of the sickle cell anemia. It is also one of the most important reason for your young stroke in the young age. Then priapism. Then we have hand foot syndrome, abdominal pain, leg ulcers because the end arteries do not get the adequate blood supply, gallstones, organ damage. All these are few of the medical complications. Now, the functional impairment, not only in the organs, but it can cause to the other parts like the vision and hearing. So we'll see how that is happening. The pain is a common experience for people with the sickle cell disease. Now, what happens in various studies, it has shown that roughly 1/3 of the patients will experience the pain crisis because of the vaso-occlusive events, and another 50 due to the more than half the days. The pain episodes, what happens because of that? It's causing a impairment. How is it causing? It is limiting the participation in the school. It is causing a problem in the activities of daily living and social events for the children. In pain, in sickle cell epidemiology, there is a study, that is the PISS study, in that they associate the pain in the activity limitation. So what happens is the baseline daily pain was a significant predictor for the quality of life. And not only the quality of life, the outcome and also the physical and social functioning. The pain is simply not the result of the biological process here, because it is not only influenced by the social context, other factors like the psychosocial stress, the negative mood, and also being shown to affect the patients, adults, the adolescents with the sickle cell disease. Now, individuals with sickle cell disease often develop the sensory impairments either in vision or hearing. Vision loss in sickle cell disease can be secondary to the stroke, or it can be from the proliferative sickle cell retinopathy. So these are the two major factors for the vision loss. Now, children with the sickle cell disease are more likely to be reported to have visual impairment. Then we have the sensory hearing loss is also reported to common children among the symptom among the children. Now, chelation therapy, which is used for transfusional iron overload and in the transfusion dependent patients, then again it can lead to the hearing vision disturbances. So we need to monitor the dose regularly and reduce the dose if needed. Coming on to the next problem is the cognition and language. So the biggest risk of permanent impairment and disability for the patients is the cognitive and psychomotor impairment. Now, this is secondary to the stroke. About 11% of children with the sickle cell anemia, they experience a clinical stroke prior to the 18 years of age. So the risk here is so much higher. You can see it is about 250 times higher than the general pediatric population. Now, the silent infarcts are the most common things. Other than that, we have the specific cognitive deficits, which can be attention deficits, executive function, which are critical for successful academic performance. The best established mechanism for the neurological impairment is if in the absence of an infarct is anemia. The several studies showing the children with sickle cell anemia have the very low hemoglobin concentration, and that predicts their neurocognitive impairment. So they may not be developing normally like how a normal child should develop because of the anemia. Okay, language deficits, which are unrelated to cerebrovascular events, can also occur in children. Then coming on to the functional impairments, now the mobility impairment can occur among children with the sickle cell disease because of the cerebral palsy. Again, this is one of the most common causes of cerebral palsy is your lesser blood flow, where the blood flow to the brain is hampered. Again, you have the functional impairment because of that. And it can also be a result of the stroke and other etiologies. Again, we have the recurrent skeletal disease due to the repeated bone infarction, avascular necrosis. Again, they may lead to a decreased bone density with vertebral disease, leading to vertebral fractures, chronic back pain, and other nutritional deficiencies such as vitamin E deficiency, calcium deficiency, etc. Now, these are the most important causes of the mobility. Now, even if there is no stroke, they have a total toll because of all these factors, like the effect on the bone, the effect on the muscle, and to the brain. They can cause a decreased mobility. Now, again, coming on to the other psychological factors, here we have the emotional and behavior problems. Now, people with the sickle cell disease, like those with other chronic health problems, they have a risk of the psychosocial or mental health problems like your depression, the self-concept, and peer socialization difficulties. Now, emphasis here should be on the behavioral or mental health, not only from the condition itself, but also from their interaction with the environment. Now, most of the existing evidence suppose that is the increased prevalence of anxiety and depression among the adults, adolescents, and children. So all the group of patients with the SCD at some point of their life, they experience these symptoms. Now, these symptoms are also predict they are in turn again related to the pain. And because of this pain, it causes a vicious cycle. So the pain, the anxiety, depression, poor physical health, and the quality of their life all are hampered in the patients with the sickle cell disease. Now, coming on to general aspects, here other general aspects like the moderate to severe anemia is a common feature. Now, this can lead to the fatigue and weakness, causing the poor performance and reduced physical and as well as the cognitive function. Now, anemia, which is very much important, is a well-established predictor for the functional decline and disability, which can either be from the reduced oxygen delivery to the muscles and the brain. Cardiopulmonary complications such as the acute chest syndrome, pulmonary hypertension, asthma can again lead to a decreased exercise capacity. Now, how do we prevent this? So as we can see, most children born with the sickle cell disease can now survive up to adulthood. They have the right to expect to live productively, to have an independent life, and full participation at work, community, and relationship. So health providers and parents, we need to track the function in the academic, cognitive, social, and emotional domains to identify the children who need help. So not all will be normal. So we need to identify where the problem is. It can be either in single area or in multiple areas. So we need to have the individual data on school, the emotional status, the social progress. We need to be available so that we can interact this and correlate them to the health status of that individual, that is the physical health, then the age and all the other domains. Now, enhanced individual health records and linkage to other systems that include follow-up, which are important for us in the follow-up. So we need to see the education level, the social services, and the mental health status of that particular individual. Now, very important factor for us is the ICF here. Now, this provides a principle and an organizational framework to guide the efforts for a better identification of the problem. So, if a patient is having a sickle cell disease, we can exactly point out where the problem is. It can either be a biological, personal, or the environmental. And with further data, we can see where the intervention exactly is needed. Coming on to the management, we'll just put up a simple thing. So prevention, we need to do a neonatal screening so we can identify the population at risk. The childhood immunization because they are at a higher risk of infections. So if for the painful crisis can be managed by the NSAIDs and antibiotics, and we need to make some certain lifestyle changes like to avoid exhaustion, to cold, high altitude and stressful conditions. Now coming on to the relationship for the revised RPWD Act, that is the rights of persons with disability. Now they have recognized the patient with the blood disorders, not only our sickle cell disease, which is our topic of interest. It is also recognized thalassemia, hemophilia, and the sickle cell disease, as rightly pointed out by the director. The first and foremost benefit for the RPWD Act is the non-discrimination. So in the past, there have been many persons with the blood disorders who have been denied employment, even though they are selected on the merits because there was because of physical condition or whatever. But with this law, with this act in place, such discrimination cannot happen. And also the act states which denying the reasonable accommodation, that adjustment will also be a discrimination. So we have to not only given the rights to the persons with the disability, we are also giving them a certain adjustment. So we'll see what are those. Therefore, an organization cannot deny any that a person may need. Important benefit to it will be the reservation in higher education. Now, this will enable the persons with the blood disorders to pursue higher education of their interest, which was not possible before. The other benefits of the RPWD are: one is the right to equality, life with dignity, and to respect his or own integrity equally with the others. Now, other few more appropriate healthcare measures such as the insurance scheme, rehabilitation programs, and other incentives by the employer may be provided on a 5% reservation basis for the benchmark disability. If the patient is having with a sickle cell disease having a benchmark disability, we can give them all those benefits. Coming on from the adjustments for the employers and the educational institutes. The private and government establishment should not discriminate between a person with a blood disorder or the individual or any individual with a particular problem. So we can give them extra time, like if they need an extra time for some their regular work or any other benefit we can give. So it can give extra leaves in case the patient is hospitalized because of his disease. It can be either be a painful crisis, a pain infection, or any other end organ problem. Okay, and relaxation in the attendance. So school and college should provide relaxation in the attendance so that he may be eligible for the exam. So also we should provide extra time for exams and assignments so that they can accommodate and do it in a proper manner. A financial assistance for the affected person, caregiver can also be done. And for posting and transfers can be only be given in certain cities, so that in the posting should be given to the person with blood disorders and their parents should be at the same place. Okay, inclusion in the extracurricular activities, and also for they should be exempted in if there is any strenuous activity involved. How they should not let the student or the individual feeling let out. So we should try to accommodate as much as they are able to cope up with a particular problem. Ensuring no bullying and harassment because of their particular disease. So there must be strict policies to ensure there is zero tolerance for bullying, harassment, or discrimination for the individuals. These are the references. Thank you.
Thank you, Ikram, for such a wonderful presentation. And if there are any questions, we can take them now.
Hello, sir.
Yes, I'm listening.
So any help for like disabled medical line?
Yes, if they are eligible for the disability certificate, then definitely, as I told, we are giving them reservations. Then again, if they are requiring any extra sick leaves, or if they're having any acute emergencies, so those all can be accommodated. That these benefits are not only in addition to the routine benefits which are being provided to the employee or the individual.
Okay, if any other questions from anybody else? Maybe not. Okay. Thank you, Ikram, for your presentation. And with that, we are
Thank you,
almost
sir.
at the end of our program. Yeah. And now we are left with the duty of expressing our gratitude where it is due. So I must thank Dr. Tufan Kanti Doloi, Professor and Head of Hematology Department of NRS Medical College, for sparing time for us among his busy schedule in such a short notice. Thank you, sir. Thank you for being with us. Thank you for such an informative presentation. Thank you so much, sir.
Thank you.
Special thanks to Dr. P.P. Mohanty, Director of NILD, who has actively participated in this program, has encouraged it, and helped us throughout with all his approvals and everything. Thank you, sir. My heartfelt gratitude to Dr. Ikram Malik, Senior Resident of Physical Medicine and Rehabilitation at NILD Kolkata, for making such a wonderful presentation, and hope to see more from you, Ikram, in this line. My special thanks to Dr. Abhishek Bishwas, who is the in charge of medical rehabilitation at NILD Kolkata, for his able guidance in all affairs. Special thanks to Dr. Rupali Sen, who is the HOD of Occupational Therapy Department, Dr. Himel Chakraborty, who is the research officer, and Mr. Himanshu Srivastav, who is the media officer, and the entire IT department for their technical support and their help in organizing in this program all along. And finally, we have to thank you all, the audience who have been here patiently throughout, waited for such a long time before starting of the program. So thank you so much, everybody. All of you being here
Dr.
has made
Saman,
this
can you
program
share your
essential.
number? Sorry to interrupt, sir. Dr. Saman, can you share your number? Dr. Saman,
Could you repeat that again?
can you share number, sir? Dr. Saman, Dr. Saman, can you share
Which?
your number?
Yeah, we can do that later. Yeah, do that later.
Okay, sir.
Okay, thank you everybody for being here. Have a nice day. Take care. Thank you so much.